Today we'll be talking about episiotomy. So, what is an episiotomy? So, when we talk about it in terms of definition, it's a surgically planned incision on the perineum and the posterior vaginal wall during the second stage of labor. Okay, it's called an episiotomy, or you can also call it a perineotomy. In fact, it's actually an inflicted second degree perineal injury. So why is an episiotomy done? We just said that it's an inflicted second degree perineal injury. So it has to be done for a reason, isn't it? So it's done to enlarge the vaginal introitus so as to facilitate easy and safe delivery of the fetus. So it can be spontaneous vaginal delivery or manipulative, where you have to use instruments. And also to minimize overstretching and rupture of the perineal muscles and fascia, to reduce the strain and stress on the fetal head. So what are the indications of an episiotomy? So one thing you need to know, that episiotomy is recommended only in selective cases. It's not a routine procedure that needs to be done on everyone, okay? So if you do a constant care during the second stage, it reduces the incidence of episiotomies and perineal trauma. Okay, so when is it done? What are the indications? One, in elastic or rigid perineum that can cause arrest or delay in descent of the presenting part, as seen in elderly primigravida. Two, when you're anticipating a perineal tear. So in what cases can you anticipate a perineal tear? One, when it's a big baby. Two, if there is a face to pubis delivery. C, if there is a breech delivery. D, shoulder dystocia. Then in case of an operative delivery, such as if you're using forceps or ventouse, you need to do an episiotomy. Then also in cases of previous perineal surgery, such as a pelvic floor repair, perineal reconstructive surgery. So when is an episiotomy done? So the timing of performing the episiotomy requires judgment. If it's done early, the blood loss will be more, and if it's done late, it fails to prevent the invisible lacerations of the perineal body, and thereby it fails to protect the pelvic floor, which is the very purpose of the episiotomy. So it's done usually when the bulging thin perineum during contraction just prior to crowning. When about 3 to 4 centimeters of the head is visible, that's the ideal time of doing an episiotomy. Then if you want to do it while doing a forceps delivery, so it's usually made after the application of blades. So what are the advantages of an episiotomy? So there's maternal and fetal. So maternal advantages are controversial whether routine episiotomy has got any major benefits. However, the suggested benefits are: 1, a clear and controlled incision is easy to repair and heals better than a lacerated wound that might occur otherwise. B, it reduces the duration of the second stage of labor. C, reduction of trauma to the pelvic floor muscles that reduces the incidence of prolapse and perhaps urinary incontinence. Then fetal advantages include: it minimizes intracranial injuries, especially in premature babies or after coming out of breech. So when we talk about the types of episiotomies, there are actually 4 types. There is a mediolateral, median, lateral, and J-shaped. However, what you need to know, the most common are the mediolateral and the median types, okay? And these are the ones we'll talk about in detail. So the mediolateral, the incision is made downwards and outwards from the midpoint to the fourchette, either to the right or to the left. It is directed diagonally in a straight line, which runs about 2.5 centimeters away from the anus, about midpoint between the anus and the ischial tuberosity. Then the median episiotomy, this incision commences from the center of the fourchette and extends posteriorly along the midline for about 2.5 centimeters. So merits and demerits of the median and mediolateral episiotomy. So what would you want to do between median and mediolateral, since you said both are common? So merits of the median is: the muscles are not cut, the blood loss is least, repair is easy, post-operative comfort is maximum, healing is superior, wound disruption is rare, and dyspareunia is rare. In mediolateral, there is relative safety from rectal involvement from extension, and if necessary, the incision can easily be extended. What are the demerits of median episiotomy? So if there's any extension that may occur, it will involve the rectum, which is something that we don't want. And it's not suitable for manipulative delivery or in abnormal presentation or position. As such, its use is selective. The demerits of medial lateral episiotomy include a position of the tissues is not so good, blood loss is a little more, post-operative discomfort is more, relative increased incidence of wound disruption, and dyspareunia is comparatively more. So when we talk about the medial lateral episiotomy, the structures that are cut are, so you can follow through on the diagram. So the first is the posterior vaginal wall. 2. Superficial and deep transverse perineal muscles, which are the bulbous spongiosum and part of the levator ani. 3rd, the fascia that covers those muscles. 4. Transverse perineal branches of pudendal vessels and nerves. 5. Subcutaneous tissue and skin. Complications of an episiotomy. So immediate complications include, if it's a median episiotomy, the extension of the incision to involve the rectum. 2. Vulval hematoma. 3. Infection. 4. Wound dehiscence. 5. Injury to anal sphincter causing incontinence of flatus or feces. 6. Rectovaginal fistula. Rarely you may also get necrotizing fasciitis. Then remote complications include dyspareunia, chance of perineal lacerations in subsequent labor, and a rare remote complication is scar endometriosis. So that's all about episiotomy. If you like the video, please like, subscribe, and comment. Thank you.